My name is Dr. Richard McLaughlin from San Diego, California, and I'm going to be describing the dental VTO from dolphin imaging. One of the most important aspects of diagnosis and treatment planning is to determine as accurate as possible the distance and direction that teeth in each arch are to be moved from their malpose position to their final occlusal position. More specifically, the dental VTO provides specific information concerning the movement of midlines, canines, and first molars after the desired incisor position has been established cephalometrically. The first patient is a non-surgical orthodontic case. He is a 14-year-old male presenting with a slight class 2 skeletal pattern with moderate to severe crowding in his upper and lower arches. Now let's go to PowerPoint and look a little more closely at his pictures. Here are his facial photographs, and you can see he's got a reasonably adequate facial profile, a little bit of fullness to his lips, and he shows good symmetry in his frontal photograph. This is his traditional cephalometric tracing, which is based on cranial base landmarks. This cephalometric provides us good skeletal and dental information. The next tracing is an excellent addition to the traditional cephalometrics. This is the Arnett analysis. This is based on natural head position with a patient looking into a mirror and a vertical line drop through subnasally. And from that we get a lot of soft tissue information as well as some additional skeletal information. In particular, the occlusal plane is recorded here as 99 degrees. It is based on a line through the maxillary occlusal plane and the angle that it forms with the true vertical line drop through subnasally. Here are his intraoral photographs, and you can see that he's slight class 2 on the right side. Both his midlines are deviated slightly to the right side, and on the left side he is in a class 1 relationship. Here is his Panorex X-ray and his occlusal views. You can see that his third molars are present. He has healthy looking condyles in the Panorex, and you can see the excessive crowding he has in his upper and lower arches. So when we look at our patients, what we want to do is gather information on the patient from our patient history, and from our clinical examination. So from that information we gain information in these 5 important areas. Once we've gathered information, then we begin our evaluation, and we begin by looking first at the soft tissue. Do we want to see some soft tissue changes on him? And we know that orthodontically that's going to be based on where we place his incisors. So to correct the soft tissue, we want to first evaluate incisor position, and then after that we will go to the dental VTO. So essentially we get the soft tissue and incisor information from our cephalometrics, and then we go to the dental VTO to get our remaining information. Now we are going to return to dolphin imaging and discuss incisor positioning. Here is our cephalometric tracing with the Arnett analysis, and the treatment for the soft tissue and incisor position is quite easy here. The lower incisor is in a very satisfactory position. It will remain there with a little bit of intrusion, and the upper incisor will be retracted. This can be saved and recorded as a treatment simulation, and you can see the changes that we made here, and we can take a look at the superimposition. So we return to the master page here, and then we can go to superimposition, tracing superimposition, and we will click on his original digitized lateral ceph and his treatment simulation, and then we see our movements. So you can see that essentially the lower incisor remained in its position and the upper incisor is retracted. This will change the upper lip position very slightly, so this is a very easy incisor position to diagnose with this patient. Now this information is very valuable to us for the dental VTO. We are going to carry the information, particularly on lower incisor position, to our dental VTO and carry out the dental VTO. There are two ways to access the dental VTO. One is through tools, which we can go to the McLaughlin VTO button, or the second way, if we have a cephalometric tracing, we can go through treatment planning. And both of them will take you to the dental VTO. Through treatment planning, you click on the treatment simulation mode and go to the M, and you then have got the beginning of the dental VTO. Normally when I see the patients, I have not taken my cephalometric x-ray yet, so the way that we normally proceed to the dental VTO is through tools. So when the patient first comes in, we take facial pictures, we take intraoral photographs, and we take a Panorex x-ray. We do not take the cephalometric x-ray or the study models until we've confirmed that the patient is going to proceed with treatment. So now we'll go through the tools mode to access the dental VTO. So we go to tools, drop down to McLaughlin dental VTO, and left click, and you've got the first chart of the dental VTO. The dental VTO consists of 3 steps or 3 charts. The first chart or step is to record the existing molar relationship and the existing midline relationship. If we look at first we look at the right posterior segment. I like to take it and bring it down out of the way so that I can see it. I bring it to the lower left-hand corner of the screen. And this patient, as you can see, is 1.5 millimeters in a class 2 direction. And we're looking at the molar relationship, but also at the bicuspid relationship. Now we go to the left posterior segment, and we see that the patient has a nice class 1 relationship, so there's nothing to do here. To move the cursor, we can click the up arrow, which moves in a class 2 direction, or the down arrow, which moves in a class 3 direction. So you can see on the right side, we clicked the up button and went to 1.5 millimeters class 2. Next is the midline relationship. And the patient, this has to be evaluated with the initial exam, very important to evaluate at the initial exam. And we determined that the upper and lower midlines were both 1 millimeter to the right side. So we click the lower button, and we go to 1 millimeter on the upper, and the lower arch, we go to the dental. D refers to the dental midline shift, and we're going to move the midline 1 millimeter to the right. Now, if there's a skeletal deviation of the mandible, then we can click on the S button for skeletal, and we can move midlines as needed in the skeletal direction. The upper has primarily a dental mode to it, and the lower has both a dental and a skeletal mode to it. So chart 1 is providing us with diagnostic information of where we're starting. This chart needs to be checked as we take our as we take our study models and determine centric relation position. This is a clinical photographs that are probably in centric occlusion, and therefore we want to check this with our wax bite and our molar relationship and our midline with the wax bite in centric relation. Very important to check that when we do have the models. Now we are ready to proceed to step 2 or chart 2. So we click on the next button, and it moves us to a very thorough lower arch analysis. So let's take and move the lower arch up and over to the lower right-hand side of the screen. What we have here is a takeoff of the Steiner analysis. Dr. Steiner presented information from second molar to second molar in his analysis, and we record a number of diagnostic factors down to midline, and then we proceed with treatment planning factors below that. I felt it was important to also include a 3-to-3 column as to what goes on between the canine, from canine to canine. This is important because it gives us information on what direction and how far we have to move our lower canines at the bottom of the column. And that's going to really start our third chart, which is a complete look at the tooth movements in the upper and lower arches. So let's take a look at what we have here. The first three areas are dedicated to crowding. We have anterior crowding from 3 to 3. We have bicuspid crowding, and we have molar crowding. The reason that's broken down is because we want to know what's going on in the anterior segment by itself. And in the bicuspid region, many things can happen. We may take out a bicuspid. We may have spacing in the bicuspid region, such as E-space, or we may have crowding in the bicuspid area. And all those factors need to be taken into account as we evaluate the bicuspid region. We may be taking out bicuspids later, and so the space in that area is real important to determine where we are in terms of space analysis. And the molar area is dedicated primarily to first molars, but more specifically the second molars. Second molars can frequently be adequately spaced, or they can be crowded. So let's go ahead and move into that area for the arch spacing or crowding. This patient has quite a crowded anterior segment, and he has approximately 5 millimeters on each side from midline to the mesial of the bicuspid on each side. He's got 5 millimeters of crowding. So we're going to go to the lower arrow and click in a -5 millimeters. And we do the same thing on the left side. We're clicking into the 3 to 3 column. And you'll note that this is automatically recorded in the 7 to 7 column. So now we've got noted what's going on in the anterior segment. Now we move to the bicuspid region, and of course there's nothing located on the 3 to 3 column because we are now posterior to that area. So in the 3 to 3 column on the lower right, we note that we have 2 millimeters of crowding. So we're going to click in a -2. We're left clicking here. And then on the lower left side, we have no crowding. So we'll leave that at 0. Now to evaluate the molars, we go to the Panorex X-ray, which is located in the lower right-hand side of the screen. And the second molars are erupted. They're doing fine. There's no crowding in that area. So we will leave the molar area with 0s. So now we've included the crowding segment of the analysis. And now we look at the curve of Spee. Here's our head film. Steiner suggested that we can lay a ruler from the incisors to the most distal molar and evaluate the deepest midline, the deepest point of the curve, usually is in the bicuspid area. This patient has a slightly deep curve of Spee here. You can see it on the side view. We can also measure on the study models. He has about a 1 millimeter deep curve of Spee that we want to correct, and Steiner suggests we use half that amount per side, and therefore the patient, we're going to record a 0.5 millimeter per side for curve of Spee. The midline has been automatically recorded. If we go back to chart 1 for just 1 second, we can go back, and we've noted that both midlines are off 1 millimeter to the right. The lower arch is 1 millimeter to the right, and that in correcting that, we are going to need to move the midline back to the left. We will need a millimeter on the left side, which is a -1, and we'll gain a millimeter on the right side, which is a +1. So that has automatically been recorded in the chart. So now what we have to this point is really diagnostic information in chart 1 and chart 2 down to midline. And now we're at incisor position. This becomes treatment planning information, and we know from our head film we were very satisfied with lower incisor position. we don't need to retract the lower incisors or advance the lower incisors. If we're going to advance the lower incisors a millimeter, for example, we would click on the +1. If we were going to retract the lower incisors a millimeter, we would put a -1. And of course, this is all based on our facial evaluation, soft tissue evaluation, and our incisor position on our cephalometric X-rays. But in this particular situation, the incisors are in a very satisfactory position, so we're going to record incisor position as a 0. We have reached the point of looking at the initial discrepancy. This is a time to pause and take a look at what we're really dealing with. And we note that the discrepancy in the lower right anterior segment is 4.5 millimeters. The discrepancy in the lower left anterior segment is 6.5 millimeters. In the 7-to-7 column on the right side, we have minus 6.5 millimeters of discrepancy, and that's because of the additional 2 millimeters of crowding in the lower right bicuspid region. And on the lower left side, we also have 6.5 millimeters of discrepancy. So this is obviously quite a bit of discrepancy with this patient. We are going to do a little interproximal stripping on the patient. The patient has very large triangular lower incisors. We've got quite a problem here, so we can actually gain some space by doing some interproximal reduction. So under stripping, we're going to click plus 1.5 millimeters, which is a very comfortable amount to do in the anterior segment. And you can see it does also record in the 7-to-7 column. So this helps our anchorage somewhat. And we can take a look at where we are. Where we are at this point now is the lower canine needs to be retracted 3 millimeters on the right side, and the lower canine needs to be retracted 5 millimeters on the left side. So this information on the remaining discrepancy, the total problem that we have with our diagnosis and treatment planning, is recorded as a -3 and a -5. And if you move over to this chart in the right-hand side, you can see that the right canine has been retracted 3 millimeters, as shown here, and the left canine is retracted 5 millimeters, as shown here. And this gets us moving into our tooth movements. The lower canine is the key as to where things are moving. We can look at the midline. We recall from chart 1 that the lower midline was 1 millimeter to the right, and the correction will be 1 millimeter to the left. All right, now we start to look and see what we're going to do in the bicuspid region and what we're going to do in the molar region. This is obviously very unfeasible to make a correction like this on a non-extraction basis. So we're going to look at extractions. Let's just take a look at what we have. We have a rather odd-shaped second bicuspid on this lower right quadrant. We're going to look at extracting that, so we'll go up and click on the second bicuspid here. And on the lower left side, we have a nicely shaped second bicuspid, so we're going to go ahead with and evaluate first bicuspid extraction on the left side. And you can see that down here under extractions, the computer automatically puts in 7 millimeters of width for the bicuspid. If the bicuspid is larger or smaller than that, we can individualize. For example, if the right side is an 8 millimeter bicuspid, we would record 8 millimeters, but the computer automatically goes to a 7 millimeter for us. So now we can take a look at our the lower right side of the screen, and we can see tooth movements. As we said, the canine is going to be retracted 3 millimeters on the right side. We took out a 7 millimeter tooth, second bicuspid, but we have 2 millimeters of crowding there. So we're only going to gain 5 millimeters on the lower right bicuspid region. And that is recorded in this area here between the canine and the molar. And therefore, if the canine is going back 3 millimeters, we've got 5 millimeters of space gained with extraction and crowding. Then the molar is going to come forward 2 millimeters. We go over to the lower left side. The canine is going to be retracted 5 millimeters. We're going to extract the first bicuspid, and because there's no crowding in that area, we're going to gain the entire 7 millimeters of space, and therefore the lower molar comes forward 2 millimeters on the lower left side. So now we've got a very nice look at what our anchorage demands are in the lower arch, where teeth are going to be moving, and that's a very good record for us as we move forward. And at this point, if we want to make any notes on where we are, any comments about this, any special features, we can go to Notes, open that area up. We can type in any notes that we might want to add, and then when we're finished we can close. That'll automatically be saved in the Notes area. So we've now completed the second step or second chart. So now we can move to the third step or the third chart. We can hit the next button on the lower right hand side, and what we see here is a recording of the same information that we had on the previous page, lower arch evaluation. Here it is in the lower right hand side of the second step or the second chart. That information is recorded. And now to move to the upper arch, we look at the molar relationship. Let's go back to chart 1, and what we notice is that we are 1.5 millimeters class 2 on the right side, and we are class 1 on the left side. So we'll now note how the computer adjusts for that in the third chart or third step. We brought the lower molar forward 2 millimeters based on our canine movement and space gain in the bicuspid region, and therefore to correct the 1.5 millimeter class 2, the upper molar can come forward 0.5 millimeter. That's automatically recorded. On the left side, we noted that we were class 1, and the lower molar is coming forward 2 millimeters, so to remain class 1, the upper molar can come forward 2 millimeters. So the movement to the upper arch is based on where the lower molar is and what its relationship is to the upper molar. And now we decide if we're going to be looking at extractions or non-extraction. We extracted on the lower arch. We obviously have quite a bit of crowding here in the upper arch, so we're going to go to the middle section here with the recorded 0 zeros, and we're going to add in 7 millimeters for extraction of the upper right first bicuspid. If the tooth is larger, we can add more than that. If the tooth is smaller, we can add less than that. On the left side, we'll do the same. We're going to take out a first bicuspid. There's really no crowding in the bicuspid region up there to speak of, and therefore we're going to gain the full 7 millimeters of space as we extract the upper first bicuspids. So now you can see the canine has been moving here on the computer, and we see we've got a rather difficult anchorage situation up here. The canine will come back 6.5 millimeters, with the molar only coming forward 0.5 millimeters. Upper midline is going to shift back to the left side as it was 1 millimeter to the right. And in the upper left quadrant, the molar comes forward 2 millimeters with 7 millimeters of tooth structure removed, and therefore the upper left canine goes back 5 millimeters. So now we have a very nice look at what we're dealing with. We have lower arch movements here, and we have upper arch movements here. Now we have to recall that the patient is a growing patient, and therefore this is a beginning position, but if the patient experiences really good mandibular growth, then we may be able to burn more anchorage in the upper arch, and the same thing in the lower arch. But we don't know that growth factor quite yet, so we're going to go with this as sort of worst case scenario and kind of reassess as we move through the case. So if we just think in terms of mechanics, in the lower arch we've got a pretty good discrepancy, so we're going to go with a lower lingual arch for our anchorage, and the upper arch we're going to go with a Nance arch. In severe cases we might decide to use mini implants in the upper or lower arch to help our anchorage. Other methods of anchorage control can be evaluated based on the mechanics used by the doctor. Over here you'll note that we have some areas for class 1 molar relationship, class 2 molar relationship, and class 3 molar relationship. In this case, we're taking out upper and lower bicuspids, and therefore we're going to remain in a class 1 relationship. If, for example, we have a case where we're going to take out upper bicuspids only and plan to leave the molars in class 2, then we can go to a class 2 relationship. If, in those unusual situations where we take out only lower bicuspids, we might end up in a class 3 relationship. So that's important to keep that in mind as we set the molars in class 1, class 2, or class 3. This patient goes back to the class 1 relationship, and here we have the proposed dental movements for the case. It's nice to record this. We can refer to this at any time during treatment. Let's say we're 6 months into treatment, we're in the middle of a busy day, and we want to review what's going on with the case. We can quickly turn to the third chart or step, proposed dental movements, and see exactly what our plan was as we proceed through treatment. And one last point before we proceed to our surgical case. You notice in the upper left-hand corner there's an ortho button and a surgical button. The program automatically moves to the ortho program, and that's what we recorded here, the 3 charts for the orthodontic dental VTO. So we have completed the dental VTO in the orthodontic mode, and now in the upper right-hand side you see 3 areas that we can click on here. We want to save what we've done, so we hit the Save button. And we say, yes, we want to record everything that we've placed in the 3 charts. If we choose to print this out, it's a very nice printout. We can hit the print button. We can print this out if we want a hard copy of it. That can be very helpful to keep in the chart in certain situations. And then when we're finished with the patient, we can go to the Done button, click on that. And now we're back to our main screen, our master page. So now we can go to the final time point and see the patient's final results. Here he is facially from the side. Notice the lips are at rest for establishing lip thickness and interlabial gap. Here he is in the frontal view, and here he is with a smiling photograph. Here is his cephalometric tracing with her incisors, lower incisor was at 96. We can look at the superimposition and see where that incisor is. And so you can see fairly similar incisor position, a little more torque on the root in the final X-ray. All right, here is his right side occlusion in class 1. Notice that the upper bicuspid is slightly smaller than the lower bicuspid, so he ends up just a little bit class 2 on that side. Here's his frontal view showing overbite. And here is his left side occlusion, again slightly class 2, large lower second bicuspid and smaller upper second bicuspid. There's his upper occlusal view, and there's his lower occlusal view with his bonded retainer. So now we're going to move to the next patient, which is a surgical patient. To access this second surgical case on Dolphin Imaging, we go to Patients, and we left click, and we will type in her last name, and that'll be recorded in the upper part of the screen here, and then we can go to Find Now, and that will bring up her case. Now we can click on the OK button. So here is the master screen on our surgical case. This is a 21-year-old female showing a severe class 3 skeletal dental pattern. When she was very young, she had her first bicuspids extracted with no extractions in the upper arch. So let's move to PowerPoint and take a closer look at her pictures. Here you see, to begin with, her facial photographs. You can see she has very nice features here. She has attractive hair, beautiful skin, beautiful eyes, but the parts don't line up as well as we'd like to. She has fairly good symmetry in her frontal picture. Here is our traditional cephalometrics, and we see that she is a fairly severe class 3 with a ANB of -3 and a width of -10. Upper incisor torque is actually quite good here at 116 degrees to the palatal plane. Lower incisor, however, is very upright at 61 degrees to the mandibular plane. You can see that she's edge to edge in the anterior segment. We go to the Arnett analysis, and we have our true vertical line running through subnasale. And you can see here that she has actually a fairly nice upper lip position. Upper incisor is 10 millimeters away from true vertical line, which is a very nice position. She does show some midface deficiency. In the lower arch, you can see once again her lower incisor is very upright. Her occlusal plane is actually fairly level. She has a fairly nice level occlusal plane, as opposed to a steep occlusal plane, which many class 3 patients demonstrate. You can see the prominence of the chin here in this class 3 patient. Here are her intraoral pictures, and you can see that she's very class 3 on the right side due to her skeletal pattern and also due to the removal of the lower first bicuspid. Her upper midline is going to be on skeletally and dentally. Her lower midline is skeletally off 1 millimeter, and on the left side she is also very severely class 3 for the same reasons, the skeletal pattern and the early extraction of the lower first bicuspid. Here's her Panorex X-ray and her occlusal views. You can see the significant tipping into the extraction sites here, with roots actually moving in the wrong direction, and in the upper arch we just see the crowding. Her third molars are present in the upper and lower arches, and you can see her lower arch shows the tipping and the crowding, and in the upper arch we can see quite a bit more crowding because of the presence of all the bicuspids. So once again, as we gather information from our history and our clinical exam, we want to evaluate these 5 very important areas. Once we have completed that and we've got our problem list set up, then we can go to our treatment planning ideas. And once again, we want to look at the soft tissue and see what we want to do. And as orthodontists, we need to put the incisors in the correct position to support the soft tissue. And then lastly, we can go to the dental VTO and determine the remaining dentition. So here's our cephalometric X-ray, and we can go through a treatment planning mode, and here we see a superimposition. This can be done in the treatment simulation mode on Dolphin, which I will show you in just a moment. It can be done by hand as you wish, or it can be done through the Arnett analysis and the Arnett cephalometric treatment planning mode. And then this would be the recording of where we would be with this patient. Just to make a note here, the maxilla was in a fairly nice position. The surgeon actually wanted to move the maxilla forward to minimize how much he moved the mandible back in terms of the airway, and so that was a combined decision made by the surgeon and by myself to actually do some maxillary advancement on this patient. Even though the numbers look pretty good, for the sake of the airway, the maxilla was moved forward, so the mandible wasn't moved back quite as far. All right, now let's leave the PowerPoint and return to our Dolphin main screen. And here you see recorded her digitized lateral ceph. You see a lateral tracing overlay, which can be done to place her face into the cephalometric X-ray and then again our treatment planning x-ray. So once we've completed this information, we can now move to the surgical VTO. We're going to go back to Tools and begin recording our charts. The surgical VTO will be accessed here in the upper left-hand area under Surgical. And of course, the difference between a surgical case and an orthodontic case, surgical cases we treat the upper and lower arches independently, and then the surgeon will move the arches for us surgically. Whereas in the orthodontic VTO, we actually have to coordinate the upper and lower arches together. Surgical VTO then is broken down into 5 total charts because we are doing a separate analysis in each arch. So now we go back to Tools once again. And we'll open up the VTO. And because this is a surgical case, we're going to go up to the upper left-hand corner and hit the surgical button. And now we're into the surgical VTO. You'll note the charts 1, 2, and 3 are similar to the orthodontic VTO, but there's an upper and arch analysis and then an upper tooth movements. That'll be the difference. So let's take a look at the first chart, and here we're going to look at the right molar relationship, and this patient is 12 millimeters in a class 3 direction. So a very severe class 3 because of the skeletal pattern and because of the missing lower bicuspids. On the left side, the patient is 10 millimeters class 3, so we'll record 10 millimeters in the class 3 direction. Easy to overshoot the mark, so I had to back it up to 10. Midlines, the upper midline is symmetrical and the lower midline is skeletally off 1 millimeter. So here we record it as a skeletal problem, and the surgeon will correct that in his treatment process. Again, we need to check this chart with our wax bite and with centric relation. Next we go to chart 2, which is the lower arch discrepancy, very similar to the orthodontic analysis. And we bring her lower arch photograph up by clicking on it, and then we set that off to the side so we can see the lower arch at the same time we view the lower arch discrepancy chart. So the patient has 3.5 millimeters of crowding on each side in the lower anterior segment. We're going to count the crowding in the anterior versus the bicuspid region here. So we're minus 3.5 millimeters per side. Now, interestingly, her lower bicuspid is missing, and so the best way to handle this is actually to make it 7 millimeters crowding for the bicuspid that is missing. So we're going to add in 7 millimeters of crowding, and of course we'll take that tooth out a little bit lower on the chart. But that's a good way to do it. It's not so critical in this situation, but many situations there's varying amounts of space in there, and this is advantageous to add in the crowding of a 7 millimeter bicuspid here in the bicuspid region. The molars are fine. The lower curve of Spee is slightly deep. We can take a look at each side. Of course, the models are the best to observe this, but you can see here there's a little curve of Spee in the lower arch on the right side, and there's a little curve of Spee on the left side in the lower arch. So we do have some leveling to do, so we're going to record that into the curve of Spee area. We're going to put a millimeter for each side for curve of Spee leveling. The midline is skeletally off, and so it's not recorded as a dental problem, and hence when you look at the midline area, you won't see any additions or subtractions because the surgeon will correct that, not the orthodontist. And lower incisor position is a big factor here. The patient was very upright, as you may recall, at 61 degrees to the mandibular plane. We can't bring the tooth forward to 90 degrees to mandibular plane. However, we can bring it forward a great deal, at least 4.5 millimeters, which will bring it to about 80 degrees to the mandibular plane. So we're going to record plus 4.5 millimeters for our incisor correction. We will advance that lower incisor carefully as we begin leveling the lower arch, and that's going to take care of virtually all of our discrepancy here. You can see the lower anterior segment is basically zero because of the crowding and the curvus B issue, and then the advancement of the incisors. And now we will go ahead at this point and take out the first bicuspid that's already missing, and you can see that's going to generate a 7 millimeter return of space, and that basically canceled out the 7 millimeters that we added in for crowding the bicuspid. So they kind of cancel each other out, and that's probably the best way to do it. So the lower arch is really quite straightforward. We put the appliances on, we level the curvus B, and we align the teeth. It will take some time because of the difficulty of uprighting the roots in the bicuspid extraction site, but from a mechanic standpoint, it's essentially a leveling problem and advancing of the lower incisors. And we see this in our third chart, where essentially the canines are going to stay about where they are and the molars are going to stay approximately where they are, and it's just a matter of leveling and advancing the incisors. So now we move to chart 4, which is a newer chart. You can see that that is actually labeled as step 3 of 3, and I referred to this area as the third chart, but it's actually the third page that we're using, but it's in essence the fourth chart that we are using. So in the upper arch, let's take a look here. In the upper right quadrant, we have 4 millimeters of crowding. So we're going to record a -4 in the upper right anterior segment. And on the patient's left side, we have 3 millimeters of crowding. So we're going to record a -3 on the left anterior segment. Now we look at the bicuspid region, and you'll notice that we have about 1 millimeter of crowding in the right bicuspid, 1.5 millimeters of crowding in the right bicuspid area. So we're going to put a -1.5 millimeters. And on the other side, we have more crowding. We actually have 2.5 millimeters of crowding in the bicuspid region. So as we remove the bicuspids in this case, we're not going to gain the full amount of space for the size of the tooth. We're going to gain less space, as we will see. So now we look at we pause and look at our initial discrepancy, and we see that we have a 7 millimeter problem in the anterior segment, and overall with the bicuspid crowding we have a total of an 11 millimeter discrepancy. And so here we'll go ahead and take out the first bicuspids. And sometimes it will record a slightly odd number. We're going to just move that up to 7 millimeters to make it more straightforward. And then we can see what the results are here. So we can set this back here. And now we look at the fifth chart. And that tells us the movement that's going to go on in the upper arch. The upper right canine is going to move back 4 millimeters. It'll need to be retracted 4 millimeters. And here we see the 4 millimeters where we gather that information at the bottom of the 3 to 3 row on the right side. And on the left side, the canine will be retracted a total of 3 millimeters. We will gain 5.5 millimeters in the upper right bicuspid region because of the 1.5 millimeters of crowding, and therefore the molar will come forward 1.5 millimeters. On the left side, we have 2.5 millimeters of crowding, so we won't gain 7 millimeters with the bicuspid extraction, but only 4.5 millimeters. So then the molar will be coming forward 1.5 millimeters. So we see we have just a minor anchorage problem in the upper arch, and the first bicuspid extraction was chosen here to set the upper arch in a position ready for surgery. So now we can save this information, hitting the Save button, and then we can say Done, and it'll take us out of the VTO and back into the. So now we return to the main screen, and we then begin her treatment. Upper bicuspids, as we said, were extracted. The case was level and aligned, and then a surgical maxillary advancement was carried out along with a mandibular setback. So now we can go back to PowerPoint and take a closer look at her final pictures. This is her dentition, showing the final dentition results. These are her Panorex X-ray and her occlusal shots. You can see the bicuspid has been uprighted here in the cuspid and canine area. Upper arch extraction of first bicuspids. You can see the plates for the mandibular setback and the plates for the maxillary advancement. This is her final facial result, and her maxilla was moved forward even though her numbers were fairly good, and she has a little bit of fullness to the profile, but we're seeing this fairly often now with surgical decisions to move the maxilla forward with